You definitely
David.
don't.
Okay, you're off mute.
Okay, thank you. Good afternoon, everyone. It is April 11th at 1:00. And I'm opening this meeting, this fourth committee meeting of 3610. Welcome, everyone. Welcome everyone online. Can we just get a roll call really quick?
Senator Solomon,
It'll be late.
Senator Canope.
Here.
Representative Sanchez,
Here.
Representative Reschke,
Absent.
Doug Barrett. I can see him in the chat.
Maybe he's having trouble with his mute button, as people often do.
Vaughn Berry, Rob Corbett,
Here.
Annalise Dolph,
Here.
Jamie Floyd,
Here.
Dr. Tom Jean,
Here.
Todd Jeter, John Colmer,
Here.
Sarah Lochner,
Excuse me. Absent.
Jana McCamey. Oh, she's online, I see her. Okay. Director Prince,
Here.
Marcus Reed,
Here.
Jason Renault. I believe he said he's gonna be arriving late. Danelle Romaine,
Here.
Solara Salazar,
Here.
Aaron Sarnoff Wood.
Here.
Quorum is present.
Thank you, Adam. Okay, I actually have the work plan in front of me right this very minute, but opening it up to any discussion about the work plan thus far, I felt like we got a pretty solid place last time. That we weren't shifting too much else. Any other questions, concerns, thoughts about that piece at this point? People have it.
Nothing's changed, right?
Nothing's changed. No. We really don't want anything to change right now. So as long as there isn't any other discussion about changing, is that assuming there's feedback from members? about changes?
Yes, of
Okay.
any changes.
Does anyone have any questions or concerns about anything in the work plan at this point in time? Anyone online? Can't see. Oh, there it is. People.
And the only question is that we are going only up to June 12th and whether anyone has any suggestions for additional topics thereafter. But we will add, that's the only change that will happen is only during this.
Okay.
I had a question.
Sure.
So last time, Rep Sanchez, you mentioned vacation or taking time off, and I was like, oh, I should do mine, whatever those dates were. So what was the August dates that we weren't gonna be doing anything?
Between the 1st and the 15th.
Okay, so
Yes, for sure. Those two are on the schedule and we said, yeah, that's. My hope is that, right now we will have gotten through most of the planned presentations that we wanted to get through and that those June dates would be available to us for discussion and just really, just clear conversation about next steps, if we can get to that place. And any dates again beyond the August time that we would be able to be able to get to our final report. Perfect. Okay. Issues being reviewed today, alcohol abuse prevention, so I just want to note, first of all, though, or unless you have that on there, because I didn't notice it, that there were some questions that were asked. And thank you, Solara, for responding to the ones that were addressed specifically to you. I know that we're going to get to some of those as well today, but I just wanted to make sure that people were aware that there were responses that were sent by in your email, that you had them available to you if you had other questions or wanted to jump off with that. But we will be answering a lot of those questions throughout the discussion today. Okay? All right then. All right, highlighting role of our system partners, counties, tribes, CCOs, and community-based partners. Tatiana. I cannot say your last name, I'm so sorry.
Oh, that's okay. That's a lifetime challenge for me.
I'll bet. Spelling it.
Hi, everyone. My name is Tatiana DeOrton. I'm the Alcohol and Other Drug Prevention Systems Manager at the Oregon Health Authority. My role is rooted in the Public Health Division, but I work across the enterprise. So when we use the phrase enterprise, it means across the system of care. And so I am just here today to really lift up, first of all, thank you for the work you all are doing. This is deep, challenging, hard, sticky work. And I'm just so thankful that you all keep putting your arms around it and continue to support the critical conversations and making sure that key partners are around the table and contributing and participating in the planning and the conversation. I am building on, so Sam Byers, who's my counterpart in the Behavioral Health Division, was here a few weeks ago and did a little like promo for the psych fiscal analysis that will be coming back in later in May and doing a deeper dive on. And she started to lay the groundwork with you all about what does that psych continuum of care look like? And she talked about this arc, right, of prevention, harm reduction, treatment, and recovery. And so today is really starting to kind of fill out those components of the comprehensive continuum. And so I'm so excited to have our local public health authorities here today to tell the story of what primary prevention looks like at the local level. We'll be coming back as a state partner to talk about what does that look like at the state level and how do we support our local partners. But today is really to lift up the voices of our local partners and for them to tell the story about where do they fit in the system. Last week, I believe you had this amazing presentation from people with lived experience and telling their personal stories. That's really an important part of the continuum, right? In the sense that all of us are touched by substance use. And whether we had had that own personal lived experience or we have people in our families or in our communities, no one is untouched by this issue in our state, in our country. And so I'm really excited that you started that kind of continuum conversation with people who've had direct experiences last week. Today, our local public health authorities will talk about that piece of the continuum that's focused on prevention, kind of what that piece looks like. And then Rosie, I believe next week you'll be hearing the voices of our government to government, federally designated tribes, as well as our mental health county providers. And I believe that you also have some CCO representatives on the task force. So that's another partner we want to lift up, even if they're not doing a formal presentation. The services that they support and need that are supported and funded through Medicaid are really another really important part of the system. The other voices that are really important, in addition to the ones that I've just highlighted, are culturally specific and linguistically specific community-based organizations. And as we'll talk about later in May when we come back, in the world of alcohol primary prevention, we do not directly fund any of those partners at this time. And yet we know that the harms are disproportionately impacted on those communities. And so I'm really interested to see how we'll be able to work on that as a task force and as a community to think about how to make sure resources are equitably allocated to those communities. And so I'm just here to support our LPHA partners and just support conversation and question and answers. And we'll turn it over to some very capable prevention leaders in the state of Oregon. I'm excited to hear about the work that they're going to be sharing. So thanks for letting me be here today, Rosie.
Okay, so we are going to, all right. That was shorter than I expected. And we're gonna have lots of time to chat later on. That wonderful.
Can I ask just one question?
Sure.
Do you know, whether OHA or someone keeps a list of all of the different SUD providers? Because this is something that always confuses me at the legislature. Like, who are the different, you mentioned the CCOs and then the tribal partners and the, there's so many different providers. And is there a, like a list or something of who is providing these services?
The short answer is yes, but there's no centralized list, right? So every part of that continuum, because the way we get federal funding and the way it comes down to us and even our state funding, is pretty siloed up across those 4 components. And so our systems that support that funding also are pretty siloed up. So we can go and find that information kind of section by section, but there is no universal kind of centralized list. And I think that is part of the aspiration and hope of the fiscal analysis and why I'm personally so excited about it, because it's going to be the first time we've ever in the state of Oregon had that one snapshot of all the investments across the continuum, and really almost like a snapshot of all the partners that fall within the continuum. And so that's work that we could do aspirationally, and we should do to make it easier for us to see all the partners and where they intersect into the system. And so let's put that on the list for in the future improvement, how we able to tell the story of the partners within the system. Good question.
So I just want to expand on that a little bit then. You're referring to partners throughout the entire system that are public pay or private pay?
Well, for the most part, public pay, right? Because that's where we have the ability to shape and manage those resources. And I think that's partly what today's conversation is about, is setting the stage, like who else in the system contributes to this work?
Okay.
And it's not just the public system, right? And so thinking about who are our private partners who also have a really important contribution to make, and being able to think about the totality, the collective investments that need to be coordinated and organized, running with the needle on this really stubborn issue.
And recognizing the importance of that, however, dollars that the state invests are in fact in that public aspect for the most part. Okay. Want to make sure that we're clear about that part. It's very important to recognize that there are private entities that do this work that the state does not necessarily put resources into.
Exactly.
Okay.
Yeah.
Okay. Just clarity. I think the clarity of those things are hugely important. And I just want to make sure that we're always keeping in mind what our ultimate goal is to ensure that, I mean, if there are private resources that can be, accessed in some way, shape, or form, that's important to know. But what's able to be accessed by maybe a larger population, possibly, I don't know what those numbers look like. That's going to be the important piece for the work that we're going to do here.
Can I add one
Certainly.
thing too? So thank you so much for clarifying too that there's prevention and culturally specific, and there is a list of treatment providers, both public and private. It's just a PDF because anybody in the state of Oregon has to get a license to operate. So there is a list, but it's just like a PDF, and I think OHA, you can get that through. It's public.
I think that's the one I sent over, I put a link in the
Yeah,
chat.
so we do have that has every treatment center, but there's other recovery resources that are not on that continuum.
Quickly, I understand, Jesse, when we were speaking at the last meeting, you mentioned Oregon Recovers also developed an app. Was that something that was contracted through OHA, as I understand it? Yes.
So that we do, Oregon Recovers has an app. It's called the Recovery Network of Oregon. I talked to several of you after the last meeting about it. It's the state's most comprehensive database of resources for those in recovery that exist out there. And there's a phase 2 that we expect to launch as early as September, which is a provider portal. So the real-time number of beds. So SOAR can go in there and say, we have 3 beds for this available. So it's going to be very driven. It's going to be, the providers have to be an active participant. We think it's a resource. And this grew overnight, really just when COVID happened and there was no such resource that existed out there. So thank you, Eric. Yeah, sure.
And just see, that was funded through Care Oregon, right?
Care Oregon, there we go. Yeah, in my mind, I was like, no, it wasn't OHA. I couldn't remember who the primary funder was. Yes, Care Oregon was the primary funder of that.
What is that again? I'm sorry, CCO. That's a CCO.
Okay. You good with this one? Okay, so, Jennifer Little and Armando Jimenez, I'm assuming Jennifer is going first, so it's a panel presentation on with OHA and other system partners on the coalition of local health officials.
Good afternoon. Can you hear me?
Yes,
Great. Armando and I are actually co-presenting.
okay, perfect.
And can you see the slides
We cannot see,
online?
oh, no, hang on. Are you,
You can either share your screen or I can share it on my end and you can just tell me to flip through.
Let me see. I'm not used to Teams. Let me give this a try.
we can certainly just have Adam run the slides that he has. I'm assuming you sent them to him, yes?
I have them loaded.
If they are loaded
Okay,
in,
yeah. Why don't you do that? It's not letting me
okay,
do it. So yeah, you can just do it, and Armando and I clearly have the slides on our end as well.
Yeah.
So
Okay, one moment. I just
and
gotta
if you could
pull it up.
just indicate when you need to go to the next one.
Thank you.
There you go.
Okay, ready to go.
Oh. I can see those. Okay. Great. Well, I'll introduce myself and then Armando can introduce himself and we'll dive right in. I'm Jennifer Little. I'm the Klamath County Public Health Director and also a voting member of CLO, which will tell you what that means.
Hello, good afternoon, Chair, Task Force members. My name is Armando Jimenez. I'm a program manager at the Clackamas County Public Health Division, and I oversee the Center for Population Health, which the prevention and health promotion programs are nested in. Next slide. So just for context, we refer to the Coalition of Local Health Officials as CLO. So if I refer to CLO, that's what it stands for. But CLO is a dues-based membership association that operates to help provide advocacy, technical assistance for local public health departments. And we were asked by Sarah Lochner to provide a local public health perspective on prevention. One of the things that CLO does is facilitate and implement committees, various committees that allow us at the local level to identify gaps, barriers, needs, issues that we want to lift up, discuss, problem solve, and also make connections. So it's really been a really important part of our collaborative work because we don't see, despite our work at a local level, in my case, Clackamas County, we see this as statewide work and in many ways national work around trying to promote prevention, health promotion. One of the committees that I belong to is the CLO Legislative Committee. And Jennifer is very involved in that committee as well as the Health Promotion and Prevention Subcommittee. So before we move on, I wanted to highlight something that just recently was adopted by CLO, which is it's called the strategic framework. And it basically just is a simple way to state what is CLO priority, what are CLO priorities? And the three priorities that recently have been highlighted are legislative advocacy to make sure that we're a voice in the discussion around policy and advocacy, to advocate at the executive level, whether it's with our partners, with OHA, with local providers, and also around workforce development. So those are three important priorities that CLO has identified. And CLO is an instrumental part of helping us build our own capacity, identify funding opportunities to really connect with other partners. I think this was mentioned before about we don't see ourselves as part by ourselves. We see ourselves as part of a system with various partners that we work in collaboration with, supporting and also learning from. Next slide.
So LPHA, Local Public Health Authority, we exist in statute. And you can see the ORS listed here. We are required to provide communicable disease control, parent-child health services, or sometimes you'll hear maternal and child health, environmental health, health information and referral, reporting of health statistics. We do have to enforce and administer state public health laws. And we also are required by law to implement public health modernization, which Armando will talk a little bit more in depth about in a few slides. You can go to the next slide. So the Oregon Health Authority is our parent organization. We are their children. They pass down authority to us. And through that, we have an intergovernmental agreement. And to implement all the various programs, we have what we call program elements. So when you see these PEs on the slide, we're looking at program elements. And those are funding streams and programs that we administer. Certainly, once you've seen one health department, you've seen one health department. We all function different. We have, some of them have all of these programs, some of them have one. And so you can see here the variety of different program elements and funding streams that public health authorities receive. Some of them exist with community-based organizations. For example, WIC might be not in the public health department, it might be with a CBO. Vector control and surveillance might be its own district, it might be with a different department. For both Armando and my programs, we don't have the ADPEP or Alcohol and Drug Prevention and Education program within the public health division. It's in different departments. But this just gives you an overview of the breadth and depth of the things that we do, from communicable disease and immunizations all the way through emergency preparedness and tobacco retail licensing. Next slide. And so this gets a little bit broader around the different programs that we provide at public health departments. Some of these pertain directly to prevention and promotion, specifically with substance use, but some of them might be prevention and promotion of other things like healthy eating or immunizations or public health emergency preparedness, all kinds of different things. We also do more administrative services, again, that are in statute. For example, vital records, so birth and death certificates. We handle those things, food handlers, cards. And so this just shows you the wide variety of things that your public health departments are doing with the help and direction of Oregon Health Authority. Next slide.
So there's been a recognition over the past several decades that public health systems across the nation needed to be built up in terms of their infrastructure and improved to be able to deal with the public health issues and health issues of today, but also for the future. And in 2013, HB 2348 actually created a task force on the future of public health services. And as a result of that task force, one of the recommendations was to focus on modernization of public health. How do you improve the capabilities of public health to respond to conditions, to improve health promotion and prevention, and also to be more responsive to community-based needs based on our health equity perspective. So this visual depicts kind of the framework with which we are modernizing. And I really like to think of the bottom components where it says foundational capabilities. These are the muscle groups. If you think about our body, these are the muscle groups that we're continuously working to build. Leadership, our ability to operate in an efficient, effective way, health equity and cultural responsiveness, community partnership development, and assessment and epidemiology, which is a cornerstone, I think, of public health and public health service, is having data and using data to make decisions, policy and planning, communications, and emergency preparedness. The foundational programs are things that we feel are extremely important to prioritize: communicable disease, health promotion, environmental health, and access to clinical preventive services. But one of the things that's unique about this framework is it allows local public health authorities to have flexibility to identify those needs and strengths which make the most benefit and sense at the local level. Next slide.
So we're gonna do a little prevention 101 lesson for you, just in case you don't know, and just so we're all speaking the same language here. So you might hear primary prevention, secondary prevention, tertiary prevention. And what that means is primary prevention is preventing the thing that you don't want to happen from happening at all. So in this case, it would be, I'm trying to prevent drug addiction, or I'm trying to prevent lung cancer. And in doing that, it would be something like, well, I'm going to prevent lung cancer by not smoking and living in some place that has very clean air. That would be primary prevention, because the thing is not going to happen, or it's less likely to happen. Secondary prevention is when you're catching something early. So screenings is a really great way to think about secondary prevention. I'm getting my skin checked for skin cancer, so if I do have it, it's early enough and my outcomes are probably going to be better. In the terms of substance use prevention, secondary prevention would be something like diagnosing and treating addictions and substance use disorders really early on. We're identifying the problem, we're getting the treatment that we need to hope to stave off something worse. And then tertiary prevention is basically, we've already got the thing that we don't want. Now let's try to prevent it from getting even worse. So in this case, in substance use prevention, you get more so into the harm reduction realm. So I've already got this substance use disorder. I've already got the addiction. I'm at risk of a terrible outcome. So the tertiary prevention would be naloxone, which is an overdose reversal drug. So it's giving me one more day to try to seek the treatment that I might need before I have a fatal accident. So those are the tiers of prevention. And what we'll talk about in terms of public health is we talk about, we want to look upstream. And that means we want to prevent the thing from happening because it's more cost effective, because an ounce of prevention is worth a pound of cure. It's going to save our system money, which you learned a little bit about from one of the financial analysis presentations a few weeks ago. And very sadly, and you'll see later in our presentation, prevention is something that you don't see, and therefore it's a really easy thing to cut funding on. And we've had flat or reduced funding on local, state, and national level for years. And so we're really trying to get back into the prevention stuff. That's what public health does best. And so Armando, if you go to the next slide, can tell you a little bit more about that.
So we do our best to try to find ways to communicate with our partners and communities around what we do in public health. So we're always looking for visuals to help us do that. And one of the ones that we use is, it applies to substance use, but many other conditions as well, is we call it our continuum of response. And in a sense, basically building upon what Jennifer just described, it just shows the continuum of effort that would allow us to really make a difference, prevent bad outcomes, and really improve overall morbidity, mortality for the community. But the one thing I wanted to highlight is that we often talk about, well, what is it in public health that we focus on? What is it that we do? Well, the arrows really highlight that area that we provide support, programming, and referrals, or we actually coordinate or collaborate. We do not, in public health in Clackamas County, provide oversight or implement treatment, management, and substance use disorder. We do not operate those programs, but we work closely with programs that do. So the one thing I just wanted to emphasize is that our approach is driven by a health equity lens and a priority to reduce health disparities. So before we go to the next slide, I also want to say that this is really an opportunity for us to communicate to folks in a community how they could be a part of our work doing prevention work, especially in substance use. But the other thing is that our works goes across the lifespan. It's not just focused on school-aged youth or one particular population. we address prevention across the lifespan. Next slide. And a really good example of this is something that wouldn't traditionally be organized or put into a substance use prevention program, but it offers a unique opportunity for us to really do prevention work at its earliest stage, at a most critical stage of reducing bad outcomes. And this is WIC. So WIC stands for Women, Infant, and Children. It is a federal program funded and operated by the United States Department of Agriculture. And it's specifically aimed at raising awareness, fill education gaps, and substance use and screening for other services. It's income-based, so families that have 185% of poverty or below are eligible for this program. Primarily, it's around nutrition support and developmental outcomes, but one of the key parts of this is the screening and referral. Across the state of Oregon in 2023, there were over 114,000 pregnant women, infants, and toddlers under age 5 that were served. And this provides a unique opportunity for us to identify opportunities at their earliest stage to help pregnant moms or families that are suffering from potential issues around addiction to get them to services that they need. The WIC has also built an extremely well-coordinated system to create and build trust between families and our providers. So again, one of the important things for us is to be able to identify the possibility of reducing things such as fetal alcohol syndrome, which can have a huge detrimental lifelong impact, and also potential issues around addiction or alcohol use and complications during birth. Next slide. The other program, which traditionally wouldn't be thought of as a program within the substance use prevention world, but we feel it's extremely important, is that many local public health authorities, including Clackamas, implement home visiting programs. These are intensive programs aimed at high-risk families, many of which are struggling with addiction of one form or another. And home visitation enables us to have public health nurses providing direct parental education, navigating clinical care, referrals to basic needs, and also just being there to provide a sense of comfort and security. One of the things that's really challenging for families is to understand how to navigate the system of care and how to help them understand what to expect if they are going to enter into more formal programs. So home visiting is an extremely important part of that. And one of the things that we want to highlight is the more recent research around the Adverse Childhood Experience Study, which found that exposure to childhood trauma and toxic stress can lead to negative health outcomes throughout the lifespan. And this is something that's important for home visitors that are encountering addiction within the household. Next slide.
So like Armando said, prevention can go across the lifespan. What you do traditionally think of with prevention is with youth in the schools, which is absolutely true. And we've seen many versions of that through the decades. But also we want to focus on our college age young adults as well. But something I want to highlight is a lot of times we think of like the war on drugs and the DARE program, just say no, and it's all abstinence based, which has shown to not be the most effective and simply not realistic. But what a lot of folks don't understand is, and what public health professionals can help with, are comprehensive, evidence-based, and really skills-based programs that help to reduce misuse of whether legal or illegal substances. And what that entails are things like teaching students about positive relationships, and that could be romantic or friendship or professional. Decision-making, healthy coping strategies, which has a huge relationship with addiction. Assertive communication and letting people know what you need. We obviously have to include the dangers of drug use. And also we have to talk about the stigma around receiving mental health treatment, behavioral health treatment, substance use treatment. And then also developing community-based referral systems is huge. Like Armando already talked about, if you've got a home visit nurse that has built a rapport with you, or a WIC certifier who you've come to trust, and they say, you know, I'm seeing signs of this thing, this addiction. Let me refer you to my colleague over at this facility. In fact, here, let's make the phone call together. So those are really comprehensive and successful programs that are prevention. I will also point out that in more of the college age, I used to be an alcohol prevention educator at Oregon State University, and we did take a harm reduction approach. And I know sometimes the word harm reduction has this, you know, negative connotation to it. But what I will just say is when you get to a certain age, although yes, some use is illegal, particularly around alcohol, college age students are going to be using it. And so instead of preaching abstinence-based curriculum, we really take a harm reduction approach and say, you know, if you're going to use, let's not do binge drinking. And here's some ways to avoid that. Here's how alcohol affects your body. Here's what blood alcohol content means and how it works. Here's how your body metabolizes alcohol, so you know how your BAC is going down. And also, there's something called a syndemic, which means there's multiple epidemics happening at once. And so, for example, there might be high alcohol use happening, which leads to these unhealthy behaviors. So, for example, unprotected sex, and then we've got these STI outbreaks happening. So those are all these epidemics happening at once. And if you can do prevention, you can really prevent these issues on all of those fronts. So we really can do a lot of good with our young adults who are entering adulthood in the prevention realm. Next slide.
This next slide is really more of an example of a tool that is really important to all of us. And one of the things that's paramount to the modernization work is the ability to have data, the ability to use data and be data-driven in our decision-making. This is a snapshot from a web-based platform that we use in Clackamas, and we call it the Blueprint for a Healthy Clackamas County. And it's a web-based tool that has several different kinds of indicators. We use this as a way to help us understand trends, but also as a way to have a conversation with community about issues that we want to work together on. And so this provides an opportunity for public to look at data, to understand trends. This particular data point comes from the CDC Youth Behavioral Risk Factor Survey, which asks about consumption of alcohol for youth. So obviously we look at this in comparison to the US based on their data, and also looking at how things have gone compared to a prior estimate. And so you'll see that on here, but we use these tools to help us understand whether or not trends are moving in the direction we want. And if they are, for us to understand how that's happening, to do more of things that are working, and if they're not moving in a direction, to understand why. So we often use these tools to go to the community, have conversations, and we asked about whether or not they're observing things in the similar way. Are they seeing patterns that are use of alcohol or by youth are actually going down or up? So we have an opportunity to really have conversations and also to talk about what it is that they are doing in this area. So it really gives us an opportunity to collaborate and partner. And I feel like data is one of the important parts of the public health role. And so we work very, very hard to compile this information and make it available to the public. Next slide.
So this one, Armando and I are both going to speak on this slide. I can kick us off. We wanted to just show you, so we have our global public health budgets, and a portion of that is dedicated specifically to prevention programs. And what we'll demonstrate to you is a lot of the prevention programs are very small proportions of our overall budgets. And we would really like to see that grow, because that's really where we can see the biggest return on our investment. So for example, the Klamath County Public Health Health Promotion and Disease Prevention Division. In 2022, we had $274,000 roughly. In 2023, we increased quite significantly because of the passage of ballot measure 108, which was tobacco tax dollars. So that basically doubled our tobacco prevention funding, which was great. It is focused on only tobacco and not other substances, but regardless, it's a really big increase for us. So our budget, you can see, went up from 274 up to $459,000, almost 460. Our requested budget for this year includes not only tobacco prevention dollars, but we also have maternal and child health dollars, which we do focus on substance use prevention during pregnancy and for new parents, and also overdose prevention, which is program element 62, historically focused on opioids, but they've opened it up to all kinds of other drugs. And so what we're moving forward with in this next year is $530,000. In reference, our total appropriated budget ask for the whole health department is just under 5 million. So you can see about 10% of our budget is specific to prevention programming.
And in Clackamas, the overall budget that we are proposing for 2025 is roughly $19.5 million. One of the things I want to note is that 90% of that funding comes from federal, state, regional contracts and grants. These regional contracts and grants aren't necessarily the same every year. They fluctuate and they may be reduced from one fiscal year, 1 year to the next. The other thing is in this particular case, our prevention dedicated budget is about 8.5% of that total, primarily driven by ballot measure 108 tax revenue. Currently, this last fiscal year, about 135,000 is specifically dedicated to alcohol addiction prevention. And that is operated by a program or a division that we work very closely with in Clackamas County. But on average, per capita, about $1.36 is spent per resident per year on substance use prevention programs. Next slide. So I just mentioned the specific alcohol addiction prevention programs that we do receive funding for that we collaborate with, and we call it our Alcohol Drug Prevention and Education Program, which is ADPEP. This was highlighted in the program elements that Jennifer noted early on in the presentation. And we receive about $135,000 per year to create and support programs focused specifically on school-aged youth. The funding source is from SAMHSA, the Substance Use Mental Health Service Administration. And we use this funding to support staff to among other things, to create and oversee a prevention coalition, a local prevention coalition dedicated on school-age youth and for substance use, not necessarily only alcohol, but a broad set of substances, including tobacco, opioids, and other addictive substances. So the coalition is a really great opportunity for us to collaborate and partner with other entities in Clackamas that are doing similar work, have similar interests, serving similar populations. So it's an opportunity for us to collaborate, learn, share, and work together. The other thing that I have to highlight is that part of this work is to really partner with local school district stakeholders to do the annual student health survey, which we also use as data to help us with planning and accountability. One of the challenges has been in terms of our work with schools and school districts is incredible pressure that school districts have to just address issues around their learning and their own pursuits to get kids to be successful in their academic pursuits, to stay in school, to deal with a vast array of problems that are encountered in a school setting. So it's a challenge to introduce other topics, to ask for time from teachers, ask for time from school district administrators. So it's a constant struggle that we are dealing with. The intention of our local school district partners in Clackamas has always been extremely supportive. it's only been with what time, with what resource. And so we continuously work to try to address that. Next slide.
So you can see here, this is the ADPEP funding across Oregon for the biennium. And I will highlight Klamath County, and it doesn't come to the public health department. It goes to our mental health authority, which, like Armando said, we work very closely with them too. We try to get into the schools as much as possible, but you'll see $164,000 for 2 years doesn't buy a whole lot. It does not even pay for one full FTE. And when in speaking with our local mental health authority who has this project, she said, I mean, if we could just get one FTE, that would be a huge step forward, because then we could really help with addiction prevention across the lifespan. But right now, because it's so little, we really have to just target only what we can do with only the highest risk of people. So it's really not equitable, particularly for our most rural areas. It's an hour and a half for us to get to North County. We don't have the capacity to do that. So therefore they get left out, or they're left to fend for themselves. So, you know, you can also see on here, like what Armando said, Clackamas County also not getting a whole lot of funding. So really, we just wanted to highlight this. You can see there is a huge need for prevention funding, and public health are the trained professionals who know exactly how to use that funding to tailor to their communities. Next slide. So I want to shift gears just slightly. I hope you all know about your local alcohol and drug planning committees, but if you don't, here's your little 101. It's in statute. And the governing body of each county or combination of counties is designated by the ADPC, the Alcohol and Drug Policy Commission, which I believe this task force lives under. But each county is supposed to have a local planning committee for alcohol and drug prevention and treatment services. And we in Klamath County have a very robust LADPC, and the funding actually flows through us here at our public health department, which isn't the same across every county. But if you go to the next slide, the LADPC, like I said, is established in statute. And for us in Klamath, our mission statement basically is to plan and promote a continuum of care in dealing with drug and alcohol problems, from prevention all the way to recovery. Of course, you need everything in the spectrum. But what we've really focused on lately, since public health took it over, because it was previously held in corrections, is we said we've got to do more on prevention. This, you know, fixing the problem later on is not as effective as the prevention piece. So the funding, we actually do get funding, and it's for the beer and wine tax. It comes from DAS. For us, it goes into our finance department, and then it comes to public health, and we have that money flow out to the community through an LADPC commissioner appointed board. So we make recommendations to our county commissioners on how revenues from this tax should be spent in our county. We have pretty strict guidelines that it must be prevention, treatment, or recovery focused. And like I said, it's a commissioner appointed board who makes those recommendations, and then ultimately our county commissioners can approve or deny funding above a certain level. So we really have partnered a lot with our community partners, from the hospital, from Best Care Treatment, from Lutheran Community Services Northwest, to our behavioral health department, corrections, DHS, a wide variety of people. And so it's been a really big success for us. And, you know, the money's not a ton. We get about $70,000 a year. And for us, we've let that build up over time, so then we can make bigger investments at one time. But it is a really great partnership and a big component of prevention through treatment and recovery in our community. Next slide.
So I wanted to speak related to an example that I think is a important and relevant one, related to the use of tax revenue for prevention. And this is the example of the ballot measure 108, which was voted and approved by the voters of the state of Oregon in November 3rd, 2020, and became effective, and tax was starting to come in January of 2021, and specifically designed to allocate 90% of the revenue to state's medical assistance program, but more importantly, 10% of the revenue to address tobacco prevention, cessation, and prevention. And these dollars flow into local public health authorities. They are part of our program element. And the chart here is just a kind of a trend of our revenue for tobacco prevention support since 2017. And if you'll notice, in 2022-23, we received a pretty significant infusion of funds to help support and operate these programs in Clackamas County. It has been pretty significant on the operations side. If you go to the next slide, one of the things that's really important for folks to know, and they often ask, is ballot measure 108 tax revenue. What do you do with it? How do you put this into prevention programs in the community? So for us in Clackamas, we've used these dollars to increase staff support. Our ability to actually implement programs are dependent upon our ability to have staff to do it. We've increased that capacity pretty significantly. We've also increased investment in community-based partners. We provide grants to CBOs who actually do work in their local communities to support prevention and cessation programs. We work with healthcare systems and also tobacco retailers. And I wanted to highlight this because one of the most important parts of our work is to really build partnership with tobacco retailers. We see them as an important part of this kind of prevention constellation. And they are eager to be partners. They are eager to have understand the work. They are eager to be a part of this, and they're eager to comply with rules, regulations, and laws that are in place. So we see that opportunity to educate retailers and see them as a part of the prevention work. The other key thing is that in ballot measure 108 revenue also really allowed us to improve our ability to adapt curriculum and programs into linguistically and culturally appropriate programs, specifically for non-English speaking communities. So again, one of the other things is we've increased our presence in social media. We've increased our media outreach. We have campaigns that constantly allow us to engage youth, engage folks that want to quit. So this has really been helpful for us and also improve our data capacities. I mentioned in the slide around our web-based data platform. It's really allowed us to improve in a way to collect more data on tobacco use cessation prevalence. Next slide. And the next part of the question I always get is, oh, you receive these dollars and I understand now what you do with them. The next question is, well, how do you know you're putting this into the best use? What's the accountability? How are you making sure you're doing what you're supposed to? And one of the things that's really important about our work, especially as we work in partnership with OHA, is we are required to submit a really comprehensive work plan each biennium to actually articulate how we're going to spend the dollars, the outcomes we are going to achieve, and the activities that we will implement over the course of the year. We provide quarterly reports and participate in annual program reviews. In Clackamas, we meet regularly. In fact, we meet weekly to review budget expenditures and program milestones to make sure we're on course, we're spending on the right things in the right way. We collect a variety of performance measures and outcomes to look at progress, and we review population level data. And I wanted to highlight an example that just recently came up. We funded a pilot program to work within the clinic systems, 2 specific federally qualified health centers, to create what we called a closed loop referral system, which basically was the nurse or physician that was engaging with a patient and asking whether or not they are currently smoking, and if they are smoking, would they like to be connected to the helpline, which is a quit line that the state of Oregon operates. we get feedback around whether or not the individual that was referred actually calls, and then the physician can follow up and ask, how has that been going? Is it successful? Is there anything I can do to support that? Well, one of the things that we're learning is that the referrals that we had hoped to get are much lower than what we're expecting. In fact, they're probably around 15% of what we hope to achieve in the course of a 6-month period. So now, right now, our staff in this very moment are looking at ways of figuring out how to improve that number, or whether or not we need to change direction and look at a different way of addressing how folks in the clinical system can get support for cessation. So for me, it's really a great way of looking at how accountable we are to the programs. We can't assume simply because we put something in place that it's going to work. We always have to ask the question of whether or not it's actually getting the outcomes that we want. Next
Yeah, and
slide.
I would just add to that really quick that we've got one more slide, but like Armando was saying with the accountability process, what we try to say is, what are we doing? Why are we doing it? And how do we know? Those are key components to what we do. So really our call to action, if you want to go back just one slide, there we go. So we gave you these examples of, okay, here's what prevention means. Here's how we've already used some tax revenue dollars to implement prevention programmings. And so if there were to be an increased alcohol tax revenue that would hopefully go to public health systems who are the experts in prevention, we could see increased FTE, at a minimum, at least a 1 FTE in every county. Part of modernization, what Armando was talking about, is whether you're in rural Baker County or metro Multnomah County, we should at least have one person doing prevention in every county. In addition, like Armando talked about, increased ability to translate educational materials and media campaigns into multiple languages. We do often see that substance use issues vary depending on certain demographics, whether that's simply because of their situation or cultural activities or the way that things are marketed to them. We also could use the funding too. So we have the FTE, now we need to train them and make sure that they are, CPS means certified prevention specialists. And to keep that certification, you have to get regular continuing education units. Those all take money. And so that's what this revenue could do, is infuse some money into the workforce, making sure that they are up to speed on the best practices and they're maintaining those certifications. In addition, like I said, with the small amount of money that we're getting right now, we really have to just focus on one small population. But if we had sufficient staffing, we could really do a lot more focus across the lifespan, from maternal and child health, pregnancy, all the way through older adults who are experiencing addiction issues. And then finally, like Armando talked about, data and accountability are huge, and public health is well versed in making sure that we are either working locally or with our epidemiologists to collect the data, analyze the data, use it to inform our actions and our activities and our campaigns, and then reporting back out, whether that's reporting to the state, reporting to our commissioners, reporting to the community at large and our community partners. The one thing I will simply say is, a lot of times the legislature will say, okay, we're giving you this money, and in 1 year or in 2 years, I want to see this huge turnaround. And population health change takes some time, particularly when you're looking at prevention. It can be sometimes hard to see this immediate decline. So I would simply say that, check your expectations. And when you're looking at progress on the population level, it does just take a little bit of time, but small little incremental changes are actually quite large on the local level. So those are our slides for you. On the last slide, you can see we've got our contact information. Armando and I are both happy to answer questions now or later if you want to email us. And that's all we have for you.
Thank you so much, Jennifer and Armando. I think we have time for questions, of course, if people have them. Can we turn the screen back on so we can see if there's any hands up online? Rob?
Thank you, Jennifer and Armando. I really appreciate what you do in your communities, particularly having gone through COVID. You guys have had your hands full. My name is Rob Corbett. I'm a city manager out in Pendleton. I'm also recovering addict and alcoholic. I've been sober since 1989, so this issue's near and dear to my heart. And this whole process has been awesome for me just to learn about this topic. So a question that I have for you that I'd like you to, or I'm going to make a statement. I'd like you to comment on it if you would. I walked into Circle K convenience store yesterday, I think, and on the shelf, as soon as I walked in the door, there was a red and a green and a yellow plastic ball about the size of a cantaloupe, and it had a lid on it, and I picked it up and looked at it, and it was a daiquiri, and it was 16% alcohol. And as I listen to these conversations and I talk, and we're talking about prevention, my mind goes back to tobacco, because that's what we're talking about in terms of comparison, the work that's been done on the reduction in alcohol or use of tobacco. And you know, Cool Joe was outlawed and banned because we determined that it was making it attractive for people to smoke. And so we banned that because we didn't want people to continue smoking. We wanted people to realize the challenges of smoking, the ill effects of smoking. And it seems to me that and when I was drinking back in the 80s, the most potent form of alcohol that I could buy was 3% beer, as I recall. I think there was wine that maybe was 7%, but I was a beer guy, so forgive me if I get the data wrong. But now we're up to 16%, and it's packaged in essentially what looks like a Christmas tree ornament. And I also am aware of conversations with my police department about cans of beer that are, 32 ounces or something. They're large, they're high potent alcohol, and the whole purpose of them is to market to people who want to get high, and they want to get high fast, and they don't cost a lot of money. And so it seems to me, as we talk about the problems that exist today in Oregon about the abuse of alcohol, that maybe one of the things that we might look at are policies on what's allowed in the marketplace and how it's marketed, similar to tobacco. And I'd like for you to comment on what I just said.
Sure, I can kick us off, and then Armando, you can pipe in. Part of what we didn't focus a ton on in our presentation and prevention is the built environment. And so what you are exposed to, like you were talking about, really can affect your health behaviors. So if you're constantly surrounded by advertising or very easy access, like point of sale, you are more likely to purchase those things. Marketers have had this down for years. And so public health preventionists do focus on the built environment and what that looks like. Healthy corner store initiatives have been a thing for a few decades. What I would say is every couple of years, in conjunction with Oregon Health Authority, we conduct a TARA, a tobacco and alcohol retail assessment. And actually this coming year, we will be conducting that again. So we can go out in all of our communities around the state and identify, what do our retailer environments look like? Are the advertisements at eye level? Are they at child eye level? Are they right at the point of sale? Or are they tucked in the back? All these kinds of things are assessed. And then we can work with our retailers to say, hey, what do you think about changing up the way things are displayed? I will say though, it gets a little bit tricky when you get into advertisements and things like that. One, because of First Amendment issues. So sometimes you have to work with your code enforcement and like county zoning, those kinds of things. But also retailers receive funding from the producers of their products to display things in certain places. So you saw how tiny our prevention budgets are. Big tobacco, big alcohol, big pharmacy, way bigger than ours. And so some of these they're.
Jennifer, can you hear? Somebody has a question, one question.
Or
Producer, that's illegal under both federal and state law for producers to pay for any kind of, shelf placement or any relationship between the retailer. That's strictly prohibited.
During our presentations, we'll be addressing the three-tier system in which we'll be looking at the legal framework by which alcohol has to be sold by law in Oregon. And Oregon is one of the strictest states. I do business in many. And the OLCC is very strict on both packaging design, labeling, where it can be placed. All of this is dictated by law in the state of Oregon. You mentioned the colorful balls. That is a wine product. It's the same ABV as other wine product. It just happens to be in a novel package. And that package adheres with all legal requirements, both in Oregon and federally, to be a wine in that package. So again.
Okay, thank you. Just want to clarify.
Tom,
Yes.
Well, I was just gonna, I don't want to interrupt Jennifer too much, but in our last alcohol retail assessment, which was in 2020, we did find that, for example, 50% of retailers displayed alcohol products within 12 inches of toys or candy. So I don't know if that's illegal, but it's happening.
Yeah, I might, maybe we can address it later, but there was a number of errors in that actual report. I noticed my product was misidentified as an Alcopop. That it was high alcohol, high sugar, artificially flavored. It's none of those things. Again, I can go through that, but that report, I think, it would be helpful to have somebody from the industry spend some time with whoever's developing those reports, because it made a number of assessments that are both either illegal, not true, or made like comparisons like this can is as much alcohol as a wine. It isn't, unless it happens to be as much same alcohol content as wine. It was, I think, FMB is what it was comparing to wine. Again, these things, it's possible, but not probable.
And so I think you can quibble with a few inaccuracies in a lot of reports looked at 2,000 retailers, but I don't think that you can throw out the overall gist of what we found.
Well, and
These are people boots on the ground going throughout Oregon,
Sure.
Taking pictures and looking at things they see and reporting.
I understand what you're.
Can I ask a logistical question?
Yeah.
As we go down the show, well, so is OLCC, is there any partnership between OLCC and OHA in developing that report?
Not to what extent, I think it was OHA and local public health. Probably Craig's nodding.
Yeah, I mean, that's what I was I don't think there was partnership on that particular report, but Jennifer, do you partner or Armando, do you partner at all with OLCC when you're talking about access for minors or access for young people? Is there a partnership within your county?
I would say no. Our AdPet person, like I said, is pretty strapped and quite frankly doesn't spend a whole lot of time on alcohol issues right now. We would like to. Our relationship with our OLCC gal locally is more so just if somebody happens to report to us of, hey, my kid was able to buy alcohol legally from this place, we would just pass that report on. But Armando, I don't know if it's different with you.
Well, I was just going to say ditto, because we don't, but we should. And the kind of parallel is the dollars we've received from Ballot Measure 108 and also our tobacco retail licensing program. We've been much more engaged with retailers and folks that offer the license for the sale of cigarettes, and also a much better sense of kind of what's happening on the ground. And our staffing has been kind of the increase in staff has enabled us to have much more communication with that kind of entire network. So again, I think it's a limited capacity to be engaged with all the partners that we should be. But I would definitely say would be supportive of our kind of work to have partnership with OLCC or anyone else to be able to improve the kind of overall picture and kind of what's legal, what isn't, just for our own knowledge and also for community's knowledge.
Great, and it sounds like, I mean, that's great. I'd love to partner more, but it sounds like you know who to call if minors are getting alcohol from a licensee, you know, call us and we will do an investigation either for serving someone who's visibly intoxicated or serving a minor. I'm glad that you got that number locally.
Just want to reiterate the comment about capacity though. So different counties have different level of resources. And some counties, I'm going to use the example of Benton County, it's a university community where their commissioners in their county invest county general revenue funds and kind of partnering with the other kind of anchor funds that OHA gives them. So in that community, for example, there's really strong alcohol policy coalition with Oregon State University and all the local retailers. And so twice a year, we partner with the local OLCC liaison retailers, the university, the health department, and the hospital. They host biannual trainings for all new retailers, all staff and retail agencies and sites. And so that's an example where the lack of kind of foundational capacity that's statewide is very episodic. So communities that can kind of leverage additional resources to do that deeper partnership work have more robust systems. And then communities that don't, I think to the point that Jennifer, I think you made around equitable access to prevention resources and the policy that comes from that. So I think that's a really great example.
I would also just note that the role of public health is not to be, aha, gotcha. We are pro-business. I mean, like, we know that you can use alcohol responsibly. And so we really are just, with prevention work, we're not saying abstinence, or, well, for pregnant women, we are. But, you know, there are certain groups that we're saying prevention looks different for you, and we can help achieve that by partnering with our retailers, with our schools, with our senior centers, with our LPHAs, our CMHAs across the community.
So I appreciate, when I get to people's questions, but I do want to know that one of the things I have found very, very interesting over the many, many years that I've been doing this work and work in other areas is that whenever we do studies, and particularly we just say audits, we know that we're taking the perspective of people who are doing that work and doing that research. And that we know that somewhere, you know, once in a while, there's something that's written in a report that we're going, no, that's not true. This is my perspective on it. It's also the perspective of the people who are looking at it and also the perspective of the people who are experiencing it. So while it may be illegal to do certain things, the OLCC and the laws in this land exist because there are people who are working their way around some of the illegal. And it does happen. Just like it happens that kids are going to try to get alcohol no matter what. It's a simple reality of the situation. So I want to just sort of caution us to sort of not be, maybe, I don't know what the right word is. One does not negate the other. The reality of what the reports say does not negate the fact that the industry does see things a little bit differently and is trying to follow the rules. That doesn't mean that on any end of things, that people are always following the rules, because that's the way life is. We put, you know, as a legislator, I recognize this every single day. We put laws in place in order to address things that have already happened. Doesn't mean that that's going to completely happen. And let me tell you, I've had people literally in my face say, we'll work around that. We'll figure out a way around it. So, Senator Solomon has actually been trying to get in here, so I'm going to let her speak first, and then Danelle and Solara.
Well, thank you so much, Chair. And I just really wanted to put an emphasis behind what Mr. Corbett said, because I really do think this plays a part of this discussion. And I myself have been concerned, and I have alerted OLCC and stuff about marketing that I have seen, the bottles that look exactly like a Fireball shot, sold in a multiple pack and sold in my local Winco, right at child level. And I really do think that this marketing and the how accessible this is is part of this conversation as well. And I just really wanted to put an emphasis behind what Mr. Corbett said, because as soon as he said it, I was like, yes, I have seen this and been discouraged myself. And then I do want to say I really appreciate the presentation today. Thank you very much. Yeah, thank you.
I really appreciated the presentation too. I thought it was really interesting. So thank you so much. I have a million questions and I know I don't have time to ask them. One thing specifically, there have always been, drinks like what Mr. Corbett described. If I think back to Bartles and James, or I mean, these are not new products. They might look different because they're a modern product, but they're absolutely not new. And there are a ton of laws on the books around prohibiting advertising to youth, to anybody, encouraging anyone to overconsume, around merchandising, marketing, any type of, there's a ban on financial assistance between both producers and distributors and all types of retailers. So, and we'll get into some of that when we present, but there's a ton of laws. Whether or not they're actually being enforced all the time is another question, but this is one of the most highly regulated sectors in the state of Oregon. So I have questions about prevention, and I love the idea of some of these programs and sort of where all the different pots of money are for prevention now. When I think about what was just passed around 110 and fentanyl in schools, like, are we already doing that with alcohol too or not? I know when I was a kid, there was alcohol prevention programs in schools, like Nancy Reagan style, but is there something new, that's a question. I also think about with mothers and the training I had to sit through on shaken baby, stuff when I was in the having my kids. And I mean, it just seems like there are so many existing programs. It sounds like there are tobacco programs, there are fentanyl programs, like just there obviously are resources for prevention in different areas, but is there a way to combine some of that to make those programs more comprehensive? I'll just stop there.
Okay, we do have a little bit of time for question and answers. So anybody feel equipped to answer that specific question about prevention efforts? So that's a school situation versus a county or a city.
Well, and that's really a nice lead into when we come back in a month to do the overview of the fiscal analysis. We'll be talking a lot more about what the current investments are, not just in but also tobacco and other drugs as well. And that will also be a place where we'll talk a little bit more about the partnerships with our educational partners. It is true, right, that we have investments in these separate kind of siloed buckets of substance use prevention work. But just as the counties have shared, compared to the investment in the rest of the system, it's much, much smaller, right? And so it's much more challenging to grade funding to kind of meet those efforts just because of the level of investment. One of the things I just wanted to note, in addition to, they shared the county distribution for the alcohol primary prevention funds. That's primarily funded through our substance use prevention block grants, a federal pass-through. It's important to note that it's been over 10 years since that has been any increases in that federal block grant. And so if you think about it, it's really more like a reduction over the last decades because it's been level funded. There's a lot of work happening in the overdose space right now. That's really drawing attention to, of course, fentanyl and overdose. And one of the ways that we're trying to work as partners with ODE is to, all the tools in the toolbox that the counties highlight today, those are pretty much universal tools across, any substance use prevention portfolio work. And to really see what can we do to be creative about when we're talking about fentanyl and primary prevention of overdose, that we're also talking about alcohol and tobacco. Right, because it's what we call shared root causes. And so that's some work that's happening in the next few years to really think about kind of breaking up those pieces of separate funding and pulling them together and giving communities more flexibility to use them as they need to in the local community. Just really quick too, I know we're closing out. I also wanted to note that the tobacco example is such a great example of what a comprehensive primary prevention program can look like. So in 2023, because of ballot measure 108, we were the only state other than Maine that met Centers for Disease Control's prevention's definition of a fully funded prevention program for tobacco. And so in addition to the accountability metrics they shared, it's really proven the outcomes, right? So we've seen tobacco consumption go down consistently over the last 25 years, lower than the national average in Oregon. And then with the passage of ballot measure 108, we saw the consumption go almost down immediately. And so that's just an example that we do have successes in other areas. And so lots of things that we can learn and apply to alcohol and overdose primary prevention too.
Thanks for the follow-up on that point. That's related.
Sure. Go for it.
If you don't want me to,
I just want to make sure this is,
Okay.
it's
I'll
fine.
hold it. It's fine.
Just give me a second. Go for it.
Just a quick comment. I just think it's so sad that the ask is 1 FTE per county, and I saw the 160,000 votes per biennium.
22 in some counties.
Yeah, so my monthly operating cost for a very small treatment center is $160,000. Right? So I'm like, that is so sad that the big ask is for 1 person per county, and just, yeah, that just made me feel really sad. It could be 1 per school.
Right. So I want to just note that you all saw your minutes from last time. We had a conversation, it was a couple of weeks ago now, about just the numbers around what it actually would cost for these certain bodies in the room. And we noted at that point that they were clearly incorrect. They have been corrected in your notes, so you should have them. And they're obviously not that big. Yes, the wages were overestimated by almost $500,000. So I just wanted to make sure we talked.
$420 million total.
420 million.
420 million was the sum.
You're right.
Add that all up, it was 420 million overestimate of costs.
It's ridiculous. It was absolutely ridiculous. So, but let me just say again, bodies in the room. That is what we're missing, is bodies in the room. And it is an outrageous amount of need that we have at this point in time, and that we do not have the bodies in the room to do it. So I'm sorry, go ahead.
No, I mean, and this relates to that too. So question for Tatiana, but also for Armando and Jennifer. Annalise Dolph, I'm the director of the Alcohol and Drug Policy Commission. So I hear a lot from my commissioners and from folks in the community that over the past 10 years, there has been this perception, at least, that we once did have a more robust prevention system. So I hear what you said about we only use federal dollars. Like, what did we used to have? And what was the structure? It's my understanding we used to have a better infrastructure for certified prevention specialists than we have now, and don't require it anymore, I think, is part of what happened. So what exactly happened that led to that?
And 1 second, Chair, I just wanted to remind folks that just state your name, because the folks who are online.
That's right. I'm sorry.
And oftentimes, so just, even if you have to repeat it, it will become very
Yes.
popular, but just for this task force.
Apologies,
Thank you.
folks.
It was a reminder. Thank you.
Yes, go ahead.
Yeah, well, Annalise, those are questions that, we wrestle with. Excuse me, Tatiana Dewar, Alcohol and Other Drug Prevention Systems. So, before my time as well, I was at Benton County Health Department in the management of the Sutures Block Grant, which was called SAP at the time, lived in the Behavioral Health Division. And there was a decision at the time by Lynn Saxton and the leadership at that time to move that block grant over into prevention in the Public Health Division. And so I think part of that transition, there was infrastructure that lived over in behavioral health that didn't transfer over into public health. And also some missed opportunities around thinking about what were the partnership opportunities between public health and behavioral health. I think that my sense of what our community partners missed the most about the infrastructure that was available at that time was just really deep collaborative support of our local partners through training, through technical assistance, and through convening. In-person convening in particular to support our partners to be certified as prevention specialists and to do the work at the local level. Some of that has continued. A lot of it was severely disrupted because of COVID and just, the isolation that all of us collectively experienced and not being able to work together in the way we used to. And now, in partnership with the ADBC in particular, we're looking at how to bring back some of that infrastructure. And particularly to look at this work as not just this one funding stream, but the collective investments, right? Whether it's tobacco, alcohol overdose, and not just one federal grant, but all of the funding that goes into this package of prevention services. And so my hope is that will be returning some of those elements of that structure. We haven't had an in-person convening of preventionists in almost 5 years. There used to be an annual conference that was a regular place for people to come together to learn, to build skills. That's something we want to reconstitute and look at again. And then again, to the point earlier, these issues are so stubborn and deep that we have to have a more collective approach, right? We have to be thinking about not just the people who are funded to do this work, but really all of you, right? Everybody's got a piece of this. And so some of that infrastructure has to include other partners who haven't traditionally seen themselves as preventionists, really bringing their expertise and resources and funding to build out this system better.
So are you saying that a smaller percentage of block grants goes to prevention now? I'm still not understanding what led to the lower funding.
I think some of it is just the level funding and not seeing any increases. And then, of course, the cost to administer and support that funding increases both for staff and contract administration. And so I think some of it has just been infrastructure at the state level to just support it in the way it was, in the same way, the same level of intensity.
So there wasn't like general fund before, and there no longer is. It's always been just federal funds.
For the most part. Even we don't have full-time staff in every county, right? So we still, though, despite that, have to still piece in some other funding. So we have some criminal fines, a little bit of cannabis, and a little bit of general revenue, just to get to the point where we have partially funded FTE. So there's a lot of work to do to get to that one, at least minimum 1.0.
And that level of funding is a problem when inflation is 2 or 3% per year. When inflation goes up, it's even more of a problem year over year.
So I do want to go back to this workforce wages piece and just identify that I believe that the statement on the bottom of this is so it's overestimated is not an overestimate. It's an incorrect. It was simply incorrect, because if you'll notice where it says benefits, the number is 20,127. That would be the addition with the 68 instead of just the separate number, right? Together they would have come up to that 88, right? The same with the CADC. It's the 69,423 is the addition of the base salary with the 15,773. It's simply incorrect. It was not an overestimate. I just want to be really, really clear about that. Because I don't want there to be a perception that somebody tried to boost this number up. And let me just say, having just completed a federal grant with 3 years of funding attached to it and recognizing what it takes to do, those types of financial estimates, I have screwed a number here or there too. Thank God I have LFO in my real life work there to help out with this kind of thing. This is simply a mistake. It is not an estimate of anything. It's a simple mistake. And I just want to make sure we're clear about that. Okay. I'm gonna, unless there's any other questions on this piece.
Yes, and I apologize for stepping out. Armando and Jennifer, I love having folks from the front end of this program prevention on. So I just want to thank you for coming in. One of the encouraging areas that Dr. Tom showed us or others have shown us is youth drinking is dropping. And I just wanted to ask people if you've seen that data, I'm always verifying data. Do you see that same data? Is that correct? And what do you attribute that to if that is true? Because that's one of the encouraging areas in all of the data that Dr. Tom and Annalise have presented us.
Well, I can jump in and say that there have been some instances where we've seen decreases that likely were a result of the kids not being in organized activities in schools due to COVID. So I kind of feel that there's an opportunity for us to really dig in and start having conversations with communities about whether they're seeing that in their local neighborhoods. So it's hard to say whether that trend is a result of something that's happening that's going to continue to happen, or something that's being done at a national or state or local level to improve that outcome. So I would say, hold on, we would need more data and more discussion to be able to say if any decreases that we're seeing are real and going to continue.
I think OHA, you could probably speak to that too, because isn't this a trend that's been going on now for like 20 years? Like teen drinking rates have dropped in half. Haven't they been cut in half at least?
Binge drinking in particular, that was, I'm just pulling up, is this the graph that Dr. Seidlinger shared back in February?
That's right.
Yeah,
sure.
Yeah, so for 11th graders, it was 25% in 2001 and dropped to 13% in 2019. So that was even before the pandemic.
So why is that?
That's.
Well, it's prevention.
Part of prevention efforts having success. Also, there's long-term generational trends. I mean, there's social differences. I mean, there's lots of things we could say. It's.
I think it's important to note though, that's also a national trend.
Yeah.
And that even SAMHSA, our main federal funder, is starting to reorganize their investments and resources to move funding, to try to maintain funding for youth primary prevention, but to move it particularly to young adults and what we call transitional age youth. Because those protective factors that have helped reduce youth use as young adults move out of those protective spaces of family and school, we see those increases starting to come up again. And so from a prevention, that comment about across the lifespan, so important, right? Because these investments are important at the early end, but we have to also be investing all across the whole lifespan. And this is an example. Same with overdose, right? We see very few relatively overdoses among youth and immediately start seeing that tick up around 18 to 25. And so there's a lot of shared reasons for that, for alcohol overdose.
Thank you.
Aaron Sarnoff. Yeah, this has been a major topic in the alcohol industry. We've been seeing Gen Z, the least consumption generation, and it's declining. So I think there's been a lot of emphasis on calories, on healthy lifestyle, and a lot of people are struggling with body image issues. And there's a perception, we saw a lot of seltzers were lower alcohol, lower calorie. And I think that was a huge component to their success in their sales. And so we are seeing that this is a major issue in the alcohol industry. And there's, I'd say, easily 1,000 studies that we can dig up that show that this is a generational shift. And there's some pretty long-term dire predictions for the industry, just in that they'll have some realities that'll come with that.
I think that's so important to talk about because we're talking about a disinvestment in prevention, and yet teen drinking is the lowest it's ever been. I think as we talk about these programs, we want to make sure we're making the right investments, because from what we're seeing on our side and what it looks like is in some of the data on the public health side is that, maybe the money shouldn't be, maybe it isn't necessary to spend, focus on Gen Z. Maybe the money could be spent elsewhere. So.
Well, and I would just pipe in and just say that's why we talked about prevention across the lifespan, because it's not only about the youth. And I mean, you can see how many people are trying to get into these treatment programs and they are overrun. So you're right, maybe we just need to focus our prevention areas elsewhere, but I wouldn't disinvest in prevention because that's what gets us into these terrible spots.
We have many examples, HIV, STI, teen pregnancies, that when you pull back on the investment in prevention, those rates can go up.
Thank you. Rob.
Yeah, since we're all speculating, I do think that's a really interesting point, and it would be great if we could drill down into that a little bit. I think what's also true is that teen use of marijuana is up.
Mm.
And I think what's also true is that mental health issues for teens is up. And I think what also is true is that the data that we get to look at is there's a significant time lag between what's happening in the communities and when we actually get the data out on the streets. And so I think that's an interesting question, and I think it would be something good for this committee to look at.
Thank you, Rob. I appreciate that. Okay, so once again, would like to thank Jennifer and Armando for your presentation. Actually, very, very well done.
Thanks for having us.
Oh, yes, overall appreciating the work
Thank
that
you.
you do in terms of the prevention efforts and just there's a lot there. So thank you for your work. Okay, folks, did people actually read the questions and the responses?
And I have a question about that.
Sure.
And maybe I missed it. Like, are there questions that you want folks to answer? Like, I don't
No.
know.
Rob asked several questions. I think it was just Rob, right?
Rob
and Aaron
and Aaron
asked several questions and they were sort of put to several.
compiled in a list right here.
Yes, compiled in a list right there. We actually got some answers back, some responses.
Do you need more responses?
No, I'm asking if people have read them and have questions about them or want to discuss them further. That was my question and concern. Yes.
Yeah. So last session, you made I think it was a really interesting statement that we didn't have any data on actual bed usage rates.
Mhm.
And, I know that there's been a lot of media attention about the lacking capacity. And that, we're 50% underserved, we need 3,000 new beds, numbers like that. And, I question, okay, if we don't know how our current assets are being used, how do we come to that? And I'm familiar with the gap analysis report. And that report also did not actually, at least to my understanding of it, look at our utilization rates of any assets. It was looking at a theoretical demand based on SAMHSA data. And again, I could be incorrect, but it looks like it also relied on the years of SAMHSA data that were deemed unusable by SAMHSA for that analysis. And so I'm a little bit just trying to understand if there is another research or data showing what our needs are, or is this what we're relying on?
And
Can I
so
make one comment on that? So that is actually not accurate, and it may not have been in the report, but every treatment center, I don't know if it's everyone, I know that myself and my colleagues that run treatment centers were all contacted. And I went through a 2-3 hour meeting with the folks doing this, where I'm going over how many people I serve, how long the waits are, how many beds, going into our systems. And so I can't speak for all of them, but I will say that I did a personal, almost 3 hour survey meeting for the gap analysis.
Yeah, it includes some of that. It said, I believe 50%
Yeah.
of providers indicated they were under-resourced. The other 50% said they were already.
Okay. So Laura and Aaron
Yes.
are who was talking, folks.
So.
Okay, well, and again, we're back to how long data takes to get to where it needs to get to. That's one piece. And the other is, for me, from my perspective, I'm also looking at how many people I talk to on a fairly consistent basis who say, I cannot get in so-and-so into treatment. I cannot get them into a detox center. If they've left the detox center, we can't get them into a treatment bed long-term. So those things exist. And we may perceive them to be anecdotal at best, but they are real for the people who are struggling to find those resources.
Totally, sorry, Aaron again, totally agree. And that was leading to my next part of the question, which is, I think, Solara, you brought it up, and I think it made a light go on above my head, which is about the funding, the reimbursement rates. And my concern again was, is our capacity issue an issue of lacking beds? Or is our capacity issue an issue about reimbursement rates and providers unable to provide care because they're not financially capable of doing so because they don't get enough reimbursement for the care they're providing. And again, that was where I was trying to go with this, with the gap analysis report, is what percentages of our folks needing care are coming with OHP, and how does that relate? And, you know, ultimately, can we get a little bit deeper into that conversation? We can start to look at the finances, because it may be possible that our capacity isn't lacking necessarily in infrastructure, but more in how we're utilizing it.
Can I?
What's your name?
Annalise Stahl, Director of the Alcohol and Drug Policy Commission. And actually, Aaron, your questions and comments hit a little close to home, and I'm almost tearful about this. Our data issues are so bad in the state of Oregon. We set aside $4 million of opioid settlement board money to build a data system for SUD. That committee has paused its work because our data system is in such chaos and array. Sorry, partners at OHA, that a contractor came back to us and said, we can't actually proceed with this work right now until we get things figured out. So like, I hear you. We could sit here hours after hours for the next year. It's not going to make a data system come up. And so maybe a recommendation of this group can be, here's some data points that we would like, more accurate data, more timely data or something, so that we can start to build towards something, because we're really mired in the data space right now. So I just had to make that very direct comment. It's really hard to do my job without, I can't, like the SUD financial assessment, quite frankly, we'll all take a look at that and not feel good about it, because we don't have quality measures. There's nothing in there that says, here's our capacity. And we as a state have decided we're going to measure how many beds did we add? How much money did we get out? Instead of saying, here's our gap, how are we going to fill it?
Right. And I will just say, that was my intention in 2018. When we pushed for the Alcohol and Drug Policy Commission to come back into a form that would actually start to do some work. That was long before Emily's, by the way. I'm gonna get to you just a second. Rob. And you're off camera, sort of slipped. Oh, there you are.
Okay, so I thought I was gonna forget my question because my mind started going down the data conversation. You do not want me to go down the data conversation, because that is a huge source of frustration for me. That communities cannot get real-time data about what's happening in our communities in the area of addiction and overdose. I have, so that's a massive problem for me, because addiction is the #1 issue in every community in this state of Oregon right now. But I feel like I'm getting off topic because we're here to talk about alcohol. To Aaron's point previously, one of my questions was Solera said in a previous presentation that if you have private insurance, you get into treatment today. But if you are, and I think then I think she went on to say that if you are on the Oregon Health Plan, then God help you. And so I think that plays into what Aaron's comment was in terms of what is the need? And how much capacity is there?
Right. Yes.
Yeah, my question was actually.
And your name is?
Oh, Jamie. I was gonna say Jamie, and then I didn't. I was all excited to finally say it. But I didn't. I really was. And it's completely related. It's been on my mind since Solara brought it up. And I guess for me, when the piece about private insurance companies paying only 30% for OHP, I feel like that's got to be a statute, because a company otherwise is going to sell whatever products they want at whatever level. So I guess one of my follow-up questions is, was there something put in place that set that allows for insurance companies to charge that little? Because it just seems like a regulated space for that.
Okay, so the insurance companies, as far as I understand it, Solara, is the insurance companies are paying what the cost is, sometimes even more.
Oh, boy, this is what I do every day on Solara.
Yes.
Yes. So similar, I'm sure everybody here has been to a hospital, right, or your doctor's office. And you get so confused because you're like, oh my gosh, I have a deductible. And then it says here on my explanation of benefits that it's a $2,000 service. But then it says my insurance pays 800 and oh, look, it's a network. So they reduced the rate to 800, but I still have an out of pocket of $36. And I'm sure everybody here, including myself, has sat and looked at that and been like, this is Latin. I don't know what any of this means, and this is horrible. So what I will say is that there are some basic standards for a service bill. And then each insurance company has their own personal standards for how they pay. Some private insurance companies will pay a percentage of the rate, very few, but they might say, okay, we're going to pay you 80% of the billed rate. Then there's some that say we're going to pay 80% of the usual and customary, which is like some random national number of what they say that service should cost. Then there's some that say we're going to pay 150% of the Medicaid rate, whatever that Medicaid rate may be. Then, you know, every 5 years, there's an insurance company that says, oh, I'm just going to pay 100% of whatever you bill. I'm sure you can all agree that that's a lovely day for me when I can pay all my staff. But it's per insurance company and it's very convoluted and very confusing. If that answers it at all.
Thank you. That does answer part of my
Yes.
question or my concern was about how Jamie stated that. I want to be then clear that that is private insurance versus Medicaid, which you're talking about the 30%, right? That is us. That's the state of Oregon and their ability to get some level of federal reimbursement for that, but also just to be perfectly frank, it's not in statute that we can only pay 30%, at least as far as I know, it's not. It's simply that that's what we've set because it's what we can afford right now. We can't afford it as a state right this very minute to pay the full amount or what is needed to make sure that these systems can actually run the way they do, which is why there are private medical practices, dental in particular, that do not take our OHP clients because they simply will not take less money for what they want, for what they can do. And that's the simple reality of economics for the state itself.
And that's profound impacts for health equity.
It does. It has huge impacts because those are the people who, if you can get on OHP, it means you can't afford a whole heck of a lot more. That's the reality of the situation.
Has any of the money, the over $1 billion that's been appropriated over these few years gone to this issue at all?
Yeah, maybe rates.
Yeah.
Fee for service rates.
We have definitely increased rates. We've increased a lot of rates. We simply are not getting to that. And as Solara mentioned at one point, I think last week, was that despite the fact that our rates went up, so did the costs. So did the actual costs of doing this business.
Aaron, one more time. So is there any sort of documentation? I'm assuming there's a recommendation that goes out annually or biannually as to what that reimbursement rate would be or should be. Is that something that OHA provides the legislation, or what does that process look like? And is there any supporting arguments? Is there a process? I'm just curious, like, is this a conversation or is this just happen?
Well, Tom OHA, I think in general, a lot of that comes down from CMS, the Center for Medicaid Services at the federal level. And so they kind of set some of the reimbursement rates for everything, but I don't know exactly how Oregon takes
Yeah,
that.
so it's state based, so it's not like the rates are, but like we do have a responsibility as a Medicaid state agency to review rates on a regular basis. I think that is a good question about, I don't know the last time they
I was gonna
reviewed.
say, it's not every other year.
No, it's not every other year, and I know we're behind every year.
Yes, yes,
But CMS does have to approve the rates.
yes.
And the national standards must be a factor in that decision.
Medicare rates, but you don't have to pay a minimum. But like states have a lot of latitude. In some states politically, they balance their budget on Medicaid rates. We're actually really lucky here that providers, I don't know the last time our providers have seen cuts. but it's a state plan amendment that has to be approved. So there is a process, but CCOs can set their own rates, can contract with any provider that they want to contract with. So we have some CCOs that only contract with one withdrawal management entity. And they usually do set their rates at a minimum of fee for service, but they're not required to.
Okay, hold on. Chief Barrett.
Well, if I can unmute, and there lies the problem with the CCOs. But I'll just leave that one alone. But the state of Oregon and Lane County, which I'm in Lane County, wrote these awesome papers a couple years ago saying we're not going to put people in prison anymore. We're going to put them in treatment. Well, guess what? We still can't get them into treatment because there's not enough facilities to take all those folks and put them in treatment. NARA, which is up there in Portland, Native American Recovery Association of Northwest, which I send a lot of my clients to, has over a month waiting list most of the time. Unless you're a woman with children, then you get first priority. In those papers that Oregon said that they were going to do is we're going to build more facilities. And I don't see that happening. Of course, I don't have the overall list like you guys do. I just have the native. And the main thing we've come to a conclusion, we need dual diagnosis facilities. There's only 1 or 2 dual diagnosis facilities in the state that I know of for Native folks. So just an FYI, I hope the state of Oregon follows what they wrote and continues to do what they're supposed to do. And maybe we have to raise taxes, and maybe that's what this group is for, to raise taxes. So we do have enough money to put everybody into treatment when they need treatment. They need it now, not tomorrow, a week, or a month down the road. Just saying, I've been doing this for 25 years and it's just getting worse. Thank you.
Thank you.
Sure, why not? Sorry. Aaron, I guess the question is, will a new bed fix the problem? Does that increase our capacity if the wait list is for OHP patients, not for private insurance patients? If I can go and get care today as a cash in pocket, that tells me that there's a bed somewhere that can see me today. So is the question then that the beds, the number of beds isn't necessarily our problem, but the problem might be that there is not a bed willing to see somebody with an OHP insurance coverage?
I think we're probably somewhere in the middle there, because honestly, despite the comment that I heard a while back that there are enough beds, I do not honestly believe that that's true. And if it's just an economic issue, that's still a problem. If it is an economic issue that we cannot access treatment, and there is the reality of treatment centers that actually that look better than others, let's put it that way. That it costs more to do that, and it costs more now to do the work than it did even 5 years ago at this point. And it's we're in a difficult moment in time that things cost a lot more than they did before. And we have people in more acute situations at this moment in time. And we do not have the investment that we need right this moment in time. And I know that the conversations happen in lots of different places around the Medicaid reimbursement rates, around just overall access, opioid settlement, Measure 110, all of these different things are there. It simply still is not enough resource to put the amount of folks that we know are struggling, to put them in a place where they can access treatment if they feel like they need it right there and then. Because we don't have that quickness that we need to be able to get to that. Solara.
Thank you, Rep. Sanchez, Solara, Salazar. So I went back and I crunched our most recent numbers after our most recent pay increase that we had to do to stay relevant in our industry. And It costs us $511 per day to do co-occurring. So this is, mental health, substance use treatment. You have a doctor on staff, medication prescribing, wraparound services, case management, peers, the works. So it costs us $511 a day to treat a client at our center. So on OHP, we have for our PHP clients, which is the highest level of care, a $179 loss per client per day. So we're actually operating at a deficit of $179. For IOP, it's even more significant. That's one of the lowest paying reimbursements. And we're operating at a $399 loss per day for OHP.
Sorry.
Aaron?
Thank you. Are those payments, or those are a percentage of whatever your billing is that correct? So if your costs go up, then it's a percentage of a higher number, or is it a flat rate?
Yeah, so for costs go up. So I'm looking at, what it takes just to keep our doors open, right? So administrative costs, having a billing team, our electronic health record system, like the whole comprehensive.
Oh, I meant if your costs go up,
Yeah.
is your billing, you're billing a larger number or no?
It doesn't matter because places don't pay what you're billing. Like I said, there's
So is it a
one.
percentage or is it flat
It,
rate?
yeah, I was gonna say, it is a percentage or an actual number?
If you bill more, does it change?
No.
So it's a flat, so they pay you $300 whether you charge $1,000.
Oh, yeah,
or $10,000.
that's,
Yes,
it's a
yes.
set rate, and that's pretty standard across commercial too, is that there's usually, they have a set rate that they pay.
And
whether-
Chair, not
Yeah.
to disrupt this really awesome conversation
Yes.
that we have 5 minutes remaining.
Sorry.
And we do have, Rob Corbett.
Oh, and more.
Yeah.
I'm sorry, Rob, I'm just not looking up there enough. Rob, please.
My question for Solara was, if I run a treatment center and I'm operating with those numbers, I think one of my strategies might be to hold some beds back for private insurance and limit beds available to Oregon Health Plan. Do you think that goes on?
That's Salazar. That's what we do. We're at 50-50. And like I said, the 50% OHP is because I think people deserve help that are on the Oregon Health Plan. And even though we're operating at a deficit, I'm going to do it because it's the right thing to do. But it makes it really hard. And there's a lot of times I can make really hard financial decisions, let go of staff, cut programs, cut activities. And I don't like thinking about people as dollar amounts. It's the least favorite part of my job to turn people away that want help because I know I can't keep our doors open if I let 2 more people with OHP utilize our services.
Thank you, Solara. Did we have somebody else? And I'm just.
No,
Okay. Was there any, again, other questions on the list of questions that didn't get answered today? Okay. I'm not gonna dig deep in them if y'all are. Because some of the things did get responded to in email, so I wanted to make sure that happened. And again, reminding folks, this is a lot. It's a lot of work, a lot of information. Just want to encourage you to hang in there and assume good intentions.
And they're not questions to end all questions, Chair.
Oh, no.
They're on the website.
Yeah,
They say the
absolutely on the website.
team, put it out on the website so people can review and.
Bring them back if you want to. You're welcome to submit any new questions that you might have, and we will try to get them answered ahead of time. If we can do that, that will save us the time here in the room. While I appreciate the robust conversations and information sharing and the ability to, again, to look from all perspectives, I think it's really, really important that if we have questions, we ask them. So with that, everybody's quiet in the room for more than 3 seconds. I'm going to adjourn. Very good. Thank you so much.